Thank you very much, Yalmar. Very good for pronouncing my surname correctly. First time ever. Never heard that. So thank you very much. And thank you to our panelists. Apologies on behalf of Professor Chris Diepman. He's unwell today, so he cannot be here. But I'm sure you are going to be great. Can I please ask you to introduce yourself a little bit briefly, starting from you, Sara, maybe?
Yes.
And you can explain us how you use data-driven approaches in your work to advance health research, and what is the benefit for the public?
Yes. Okay. So I'm Sara Wade. I'm a reader in statistics and data science in the School of Mathematics at the University of Edinburgh. So I work in statistics, of course, and there's a large overlap between machine learning and statistics. So I also work in machine learning as well. And that's, of course, used to analyze data and help advance health research outcomes. So in particular, I'm, in general, interested in flexible models to analyze today's data that has a lot of complexities and challenges associated to the data, such as the volume of the data that we're seeing now. Just to mention one particular project that I'm interested in is related to dementia research, which Sotos mentioned as well at the end of his talk. So with dementia research in particular, we now often have data, multiple types of data that are collected for patients. So neuroimaging data and multiple types of neuroimaging data. We might also have other types of imaging, such as retinal imaging, biological data as well. So cerebral spinal fluid samples for each patient, which we can get biomarkers from that type of data, maybe genomics data as well, and of course, the clinical and social information collected on the patients as well. So we want to build models and algorithms that can analyze this data and possibly combine these different sources of data. And we want to build models that are tailored to the different goals that we might have in the analysis. So we might be interested in diagnosing the individual, so building a model for accurate and early diagnosis of the individuals. We might be interested in building a model that can predict dementia severity. So based on the data that we have today, can we predict the future cognitive decline of the patients? And we might be interested more generally in understanding the behavior of some biomarkers across the disease trajectory. So that's me.
That was a lot. Thank you. Atul.
Yeah, great. So hi everyone. So I'm Atul Anand. I'm a senior lecturer in the Centre for Cardiovascular Science here at the University of Edinburgh, and also a consultant geriatrician in the NHS, NHS Lothian. So I have a clinical lead role for Datalog, which is our trusted research environment for unconsented health and social care data research within South East Scotland. So we are one of 4 trusted research environments around Scotland that are regional, and we have a national one as well that coordinates alongside Research Data Scotland. So my main interests are really around unconsented large data research, particularly for older people and for cardiovascular disease. So to give you one example of this sort of data-driven work around here, we ran a trial, a data-driven trial, which was modestly called Historic, which reported a year or 2 ago. And so in that, we have a real challenge, as we heard in the first panel, about the strain on the NHS, and a very common reason why people present to hospital is with suspected heart attacks, with chest pain. So we had developed a new approach, an accelerated pathway to try and exclude heart attacks for people presenting to emergency departments across Scotland. But in order to do that in a traditional research way, you would need tens of thousands of consented patients, and also there'd be risks of bias about who you could include. So we used a data-driven approach using purely routinely entered data. We modified the electronic record system within hospitals across 7 emergency departments in Scotland. So the data that was collected was specific to enable this trial to run. And so we included over 30,000 people over an 18-month period, looking at the effect of an accelerated pathway where the unit of randomization was the hospital rather than an individual person. And so all these data from 9-10 different databases flowed into one place, and that allowed us to analyze and show that an accelerated pathway was most importantly, safe, but effective in reducing admissions by about 50% to hospital and allowing people to be discharged from the emergency department earlier. So I think we're really at a precipice of real opportunities around health and social care data. And I suppose part of it's how we make things as accessible as possible with the appropriate barriers and protections that we have to respect around unconsented data. But there's real opportunities, I think, to impact clinical practice.
Aziz.
So, hi everybody. Great to be here, Serena. Thanks for the invite. So my name is Aziz Sheikh. I'm a clinical epidemiologist. I'm Professor of Primary Care based in the Usher Institute, and I'm also the Dean of Data for the University of Edinburgh. I've been working with routine data over the last 2 decades or so. I think we've got phenomenal data assets in Scotland, in the UK. I've been using the data really for 3 purposes. Firstly, at a macro level, thinking about how our data assets can be used to support national decision making, evaluate policy interventions. Moving to a kind of a more meso level, how the data assets can be used to support improvements in the quality, safety, and efficiency of care. And then at an individual person level, thinking about approaches towards risk stratification and trying to, particularly in a preventive capacity, trying to improve outcomes in that respect. There are just numerous examples, really, of the way the data have been, I think, transformative in so many ways in those respects. But maybe one of the more recent studies is we turned the whole of the UK into a longitudinal cohort. So the first 67 million study ever done. And in that context, we were looking at under-vaccination for COVID-19 and how that was related to severe COVID-19 outcomes. So harmonised analyses running across all 4 UK nations. I think we're on the cusp of something really transformative in the UK.
Now that you mentioned that, Aziz, that was one of my questions. You have been involved in these studies called Coalesce study. It's the first whole population study of 67 million people, as you have just said, conducted across all 4 nations. So how did you solve the challenges of combining such a vast amount of data from different sources? What is the value of these kind of whole population studies? What kind of opportunities this opens up? And how we can use this approach in the future to address other diseases beyond COVID?
Yeah. Excuse me. So the pandemic for us has been an incredibly busy period. And primarily we were trying to answer questions of real policy relevance. So these were questions being asked by the chief scientist or the chief medical officer or the Joint Commission on Vaccination and Immunisation. So trying to identify policy relevant questions that we could generate timely outputs to. I think you need that kind of backing, really, if you're going to really try and do these things at scale and at pace. What it then involved was identifying senior investigators, data custodians across all 4 UK nations who are willing to roll up their sleeves and bring together teams. We developed a common protocol and analysis plan. Now, health systems have diverged across the 4 nations. We have 4 instances of the NHS. So it involved a lot of work around data harmonisation. That analysis plan was then run. These are sovereign data sets. They can't move across national boundaries. So it was then aggregated data that came into the Scottish secure environment in Public Health Scotland. Analyses done, feedback to, in this case, it was to the CMOs and the CSAs of all 4 UK nations, and then eventually a paper comes out. But what was happening during the pandemic was that whole cycle was reversed, where typically we would generate a paper and then hope for some kind of an output. Here it was just completely the other way around. We would do the work, policy would change, so vaccination schedules would change, for example. The publications would come out many months later.
Congratulations, Aziz. That was a great achievement. So my next question is about data linkage. Maybe Atul, you want to start on that. So as we all know, data linkage combines data from different sources that relate to the same person to create a new enhanced data resource. So what new insights are coming from Edinburgh today about data linkage, and what is the importance to know, what is important to know if others are interested in using data linkage?
Yeah, so I think, as Aziz has been saying, there's huge opportunities in Scotland as in England. There are common identifiers that allow us to link across multiple different data sets, and we're increasingly getting more granular in the types of data that we can bring together. It's a shame that Chris Dibben is unwell today, but he does a lot of geographical data, and spatial data, I think, is a really exciting new area. So we have just added in linkage for something called the unique property reference number, which is an ability to understand place and the type of building that someone is living in, so whether that be a care home, or also give information about where the building is in relation to something like green space. This allows a different type of analysis where you're combining health data with a concept of place as well. And also, I suppose, within, you have nationally reported type data, and that is incredibly important, allows us to make really important observations like the vaccination type work. But then there's also increasingly granular data, for example, within our hospital record systems and GP record systems that have now been digital for a long time. So we can get down to individual ward movements, we can get down to the level of how often you are seen by a doctor or a nurse within your days of your admissions in hospital. And so we can start to do some really interesting system analysis and start to bring in some of the techniques, perhaps from industry, around understanding how systems are performing, using the sorts of granular data that we never really had in a digital way before.
Sarah, anything you want to add? I saw you nodding.
Yeah. No, I mean, I think there's a lot of interesting statistical challenges that also come up with data linkage, which I don't know if you want to mention a few, but for me, what comes to mind, well, one is the high dimensionality. So once you bring all these puzzle pieces together, you're left with something that's very, very high dimensional. Even if you have 67 million patients, you can have way, way more records for each patient than that as well. So you need something that can cope with that scale of the data. Another interesting challenge from a statistical perspective is, these puzzle pieces don't align, and once you put it together, you're often left with missing patches, so missing holes in the data, missing data. And because of the high dimensionality, you often can't just remove that missing bits of the data, then you're left with almost nothing. So you need some way to impute these types of data as well.
Yes, I think, and to pick up on Sotis's point, I think the missingness is often not at random, which is the real challenge, is that clearly we get around some biases by including everybody in the population, but ultimately the data reflects healthcare interactions, and different people interact according to their deprivation background differently with healthcare services. So the data we have is reflective of biases within our systems, unfortunately.
Aziz.
Yes, I mean, the way I think about this, and completely agree with Atul and Sara there, is we can link across the entire life course for health now. So we can do that cradle to grave. There's not many places in the world where you can do this, but because everything really takes place within the NHS, that is possible using unique identifiers. I mean, health is largely determined not by what happens in the health system, it's those wider determinants of health. So we have health relevant data, and they could be relating to sort of education, work, financial considerations, environmental considerations, I mean, weather, pollution, for example. And what we've got in virtually all of these kind of instances is we've got examples of where health and those wider health relevant data have been brought together. I think the trick is going to be going forward as to whether we can do this not sort of for individual projects or programs, but whether we can do this as a scalable resource. I think Scotland is really very, very well placed to take a leadership role in this respect. We were, for example, the first place in the world that health and census data were linked. Many other countries have followed suit. But I think is the next sort of real step to be taken.
And Research Data Scotland is doing a lot of work in that.
Yeah, so we've got Roger in the room, for example, for
Roger's-
Research Data Scotland. And
Hi.
I think it's a really important next step. If we can get this right, we retain sort of pole position, I think, in that respect.
Sarah, maybe you want to start off on the next question. And it's about trustworthiness of data. So it's not always straightforward to know how complex analysis methods of large data sets produce a specific output and what are the uncertainties. So my question is, how can we ensure that data-driven innovation and transformation are done in a trustworthy way, for example, when implementing AI?
Mm-hmm. Yeah, that's a very important question. And accurate uncertainty estimation is a strong research interest of mine. And I think to answer this question, I thought I'd first tell a personal story from the other end of the spectrum. So from me being a patient. So when I was pregnant, I had a liver condition, and I was told by the doctor that I had a high risk of having a stillborn birth. So I needed to come in for multiple checkups. I needed to be on medication. But for me, I was never given a number. I was never told how uncertain they are in this number. So I myself, because I love numbers and I love uncertainty, I tried to dig in and find some papers that could tell me a little bit more about this. And the only reference that I could find that pointed me to it was a study from Scandinavia, so different population, small sample size, and it's of course studying a rare condition and a rare event. And they had, I couldn't see all the numbers, but I could see the estimate that came out. And immediately to my mind was, there is got to be a lot of uncertainty in what they've estimated there, but they're not reporting this at all. So I found that quite reassuring to myself, because obviously when you're told you're at high risk for having a stillborn birth, it's quite terrifying as a parent. So I hope this story emphasizes this point of why it's important to produce uncertainty estimates and try to find ways to effectively communicate that with doctors and patients as well. So going back to my research now, I work in models and algorithms where we want to not only focus on accuracy and prediction, but we also want to have estimates of the uncertainty in our inferences as well. And so I thought I'd just put in a little plug. We have a new hub. We've already heard, at least from Sotas, who's also involved in a different one of these AI hubs. So I'm involved in a hub on probabilistic AI. And so one of the focuses of this hub as well is uncertainty estimation. And in AI, this is particularly important. So there's some well-known examples now of using AI and machine learning. And this can give you very inaccurate, overconfident predictions. And kind of why this happens, I think it's also not well understood, but they have some kind of well-known examples. So if we take the dementia example that I talked about before, suppose you're trying to diagnose a patient based on some neuroimaging data. They've had some examples where you can just tweak the image just slightly. It still looks visibly to the naked eye the same, but the model will tell you instead of being healthy with a probability of 1, now it's diseased with a probability of 1. So the goal of this hub is to use probabilistic methods for AI to both improve robustness and to get more accurate uncertainty estimation as well.
Thank you. Anything?
I don't have much to add. I suppose just to pick up on the point about research readiness. So I think part of this is giving brilliant researchers access to the data to make sure they're getting the ability to do some of this inequalities analysis. And so I think it was mentioned, as he's mentioned, about doing things piecemeal, and really we have to move towards having research-ready data sets that include some of these really important measures such as deprivation, background, ethnicity, the sorts of things that could introduce bias, and making sure those are given as standards to researchers to do their model development in, because sometimes these things are requested by some people who want to do this work, and then others just ignore it completely, and that shouldn't really be possible.
Hjalmar, shall we move to the audience questions?
Turn it on there. Related to this question about bias and trustworthiness, we've had a question here about the panel's view of using synthetic data for training, and claimed here that it can be unbiased then, and then use real-world data for validation. So synthetic data for training because it can be unbiased, and then real-world data for validation.
Yeah, I mean, we've had relatively limited sort of experiences of working with synthetic data. I mean, part of the issue is you can produce a data set that is representative of the kind of base population. But the reason we've been trying to sort of do this is to try and sort of broaden access. But then you have to ensure that, I mean, sort of privacy concerns are met, and we've not been able to satisfy ourselves in that respect, really. I think more generally in terms of sort of validation approaches, the UK environment is now sort of sufficiently mature that you can run sort of derivation work in a particular data set and a second validation exercise in another data set. So maybe just to give a different example, we recently published a new cardiovascular risk algorithm. It's QRisk4. It's the main risk algorithm that is now used to guide prevention decisions around cardiovascular disease across the UK. I mean, the derivation work was done on around 10 million patient years of data. The validation work has evolved another 6 million patient years of data, two different sort of data instances being used. And those steps are important, but they are now possible. But you know, if I look back when we started 15 years ago, it was just very, very difficult. But you can do this work now. When we were doing the risk algorithms for the CMOs around COVID, we, for example, derived the algorithms in England and were asked to do validation work in Scotland or in Wales, for example. And again, that work was possible. So that's been our sort of preferred approach in that context.
Yeah, I mean, I always start with synthetic data, but I'm in a different field, but that's a more controlled environment where you can artificially add in some bias and test how robust the method is once you add in that bias in there.
Yeah, that's a great answer, I think. And we have another question here about I lost it. Here we go. Coming back to the pandemic and the use of data for informing policy there. After the pandemic, has the approach to informing policy at scale and harnessing this data been applied in other areas? And has the pandemic catalyzed data access to do this type of research and have this type of impact on policy?
Boy. We've just regressed, unfortunately. I think during the pandemic we had political ear cover. So I had that from the First Minister, from the Cabinet Secretary for Health and Sport, the CMO. And so we were working under a particular set of permissions that allowed us to answer questions around new variants, vaccine effectiveness, risk stratification, disease modelling, etc. So it's the kind of approach that you need. We're back to sort of our piecemeal permissions, constructing data sets for individual kind of questions. So unfortunately, we are missing a massive opportunity in that respect. And I think, given the kind of situation our NHSs found ourselves in, our health systems are kind of completely falling over. I think somebody needs to kind of seriously get a grip of this issue and enable us to begin to use the data that are there, the infrastructures that are there, the data science capabilities that are present. But at the moment, I think you can hear I'm frustrated.
Can you remind me how many applications at some point you had submitted for data access? It was kind of an incredible number. It was in the hundreds.
Well, I mean, for the pandemic, we created, it's the EVE2 data set. EVE1 was created during the last pandemic, swine flu. And then the chief medical advisor to the UK at the time, Dame Sally Davis, asked us to put that into hibernation, to bring that data set out of hibernation in a pandemic context involved 10 sets of permissions. It took almost sort of 9 months. And once we got it out, we produced the world's first effectiveness. Real world estimates of vaccine effectiveness took us 6 weeks to turn the handle and get the answer that sort of guided decisions all over the world. But yeah, I mean, I think we just missed some real opportunities in that respect.
Well, I can completely agree. I think it's balancing the expectations of the public for unconsented use. So, this is all our data. This is all of our health records. And but I think we conducted some research with Ipsos in our region around the public support in this area, and it's hugely strong. And I think much stronger than many people appreciate, even for commercial controlled access to data, as long as it's in answering a clear clinical question that is of interest to the public. I think there is generally broad support, but there's obviously a lot of concern that we will break the social contract that we all have, that we all feel we have with the NHS, that we have free healthcare, but our data is used to try and improve things. And I think there is a balance that I totally agree has moved too far back, having improved a bit during the first bit of the pandemic.
Maybe follow up then with a question then about trust from the general population and how that can be increased in order to use this data that we have to maximum effect.
Yeah, I would just a bit build on so just a brief talk about that Ipsos work. I mean, I can't remember the exact numbers, but really, really high support in the high 80% plus for this kind of work. And I think a lot of the time, actually, there is generally surprise amongst the general population that we're not already able to do this sort of stuff. So I think it's generally pushing an open door in terms of public support, but it's just making sure that the safeguards are in place.
I was chairing a session with the president of Mayo Partners last week, John Lalamka, talking about sort of the Mayo experience. So this is 10 million patients, so double the size of Scotland. I mean, the data are being used extensively, including by industry. So I asked a question around sort of public consent, I mean, opt-out procedures, etc. So this is really sold, I mean, to patients that this is vital to kind of continue to improve health outcomes. Of the 10 million, they've got 3,000 opting out. I think anybody with their right mind would understand that we have to be using these data all of the time if we're going to save the NHS.
I can continue here with here's a question about how to deal with, I think you mentioned gaps in the data, but I think there's also a question here about tacit knowledge. So, for example, I mentioned here in cases like Sarah's example, what about knowledge gained from doctors' experience and things that maybe aren't written in paper?
Yeah. If it's not in the data, it's not in the data, isn't it? That's the challenge. I think of a couple of trials that we've been involved in where we've tried to get clinical gestalt, that kind of like that intangible feeling of getting people to rate the likelihood of something and then relating that to hard data. But it's a real challenge. I don't know of any methodological solutions to that. But,
yeah, I mean, I work a lot on Bayesian methods and Bayesian statistics, and a large component of that is constructing a prior. And there's a whole field of research of trying to extract knowledge from doctors or whoever the experts are in whatever context we are in, and turning that into a mathematical formulation that knowledge is incorporated into our model. So there is a field around it, and it's very challenging.
So maybe, I mean, I can And I think one of the things is that when you start linking up data sets, you can begin to plug at least some of the data gaps. So part of the reason why Scotland moved to allow a linkage between health data and census data was, in Scotland, we were very interested in looking at ethnicity-related health inequalities. Ethnicity was really poorly coded in health data. It's a mandatory question in the census. So by driving that data linkage, you begin, you populate that data gap, for the whole country in an instance. So that's one example. Another example is, this issue around long COVID. Long COVID is a really difficult diagnosis to make. It's almost a kind of a diagnosis of exclusion. And so in the coded data, it was not really sort of present there because clinicians were reluctant to code. But what we were able to do in Scotland is we were able to interrogate the free text records using NLP techniques at a population level to look to see where sort of related kind of considerations had been recorded by clinicians. And we have the opportunity to begin to do things like that. I think the other thing that we try and bake into all of our analysis, so we try and work, so we have this triangulation. So we've got people who really understand the data sets that we're working with, the strengths and limitations. A second grouping are sort of appropriate methodologists. So we've got the epidemiologists, the statisticians, the machine learners around this. And then the third is the kind of domain-specific, the clinical expertise. So I'm working on something to do with neurology, for example. It's really important. I've got neurologists in the mix. But there are instances where we can't sort of plug the gaps, but I think some of the time we can.
Yeah, maybe try one last question here. There's a question here about, is it possible to produce high quality evidence and research using publicly available data, or do you need to have this special access in order to do good work on data in this way?
So for the healthcare data, the sort of things we were talking about, this is all held within secure environments. It's all they're held in air-gapped virtual machines so that people who are only approved to go in and work on the data see it, and it's all de-identified at that point. So all the potential identifiers are stripped, having been linked across. So I think one of the earlier questions about synthetic data, that's one of the potential opportunities if you can convince yourself that synthetic data is not disclosive, that it could potentially be analysed outside of those kind of secure environments, and that's something we're thinking about exploring, particularly for things like master's students and people where you want to try and get people working with as close to real data as possible.
Yeah, we run projects with MSc projects with Public Health Scotland using public data, and it's really difficult to answer the questions that they want to answer because the publicly available data is not at the granular level to answer those types of questions.
Again, agree, but I think it depends on the question that you're trying to answer. So we have Ahmer Shah in the room. Ahmer has just recently been working on waiting lists for the NHS for specialists. It's a piece published in The Lancet a few months ago looking at waiting lists and how they've risen for England. These are using publicly available data. He's modelled a number of scenarios around increases in efficiency that are needed to bring those waiting lists down. Some of those are finding their ways into manifesto pronouncements. There's a similar piece of work that's being done in Scotland. The numbers are alarming.
And after all this pessimism, I think we can close it here. Right, Jan?
Excellent.
Thank you very much to our panelists. It was great discussion. Thank you, Aziz. Thank you, Atul. Thank you, Sara. And I think there is one final... Over to you, Jan. Thank you very much. Round of applause.
Thank you.